This should look a little familiar because we said primarily the same thing last time we met. The context here is that over the last several weeks we've analyzed data sources and really are beginning to look for the opportunities of improvement in long-term services and supports. This is the first stage in payment improvement always. When we're developing an episode of care in the medical arena, the first thing we do is target an area, define it a little bit, and then start looking at the data and identifying whether there are opportunities for improvement. So that's what we'll talk about today. We haven't made decisions on solutions. We won't likely have a lot of time to talk about solutions today, although you may want to bring some up, and you're always welcome to do that. Primarily, the first thing is, do we know what's happening now in our program? Do we know what the trends are? Can we diagnose the challenges or the opportunities? That's the first stage. And we feel that the data do tell a compelling story and that there is opportunity, but we'd like to hear your opinion. And so we'll be sharing that analysis with you. We want to gather your feedback. What data or analysis may we have missed? That's a question for today. What additional analysis would you like to see? And we want to understand your perspectives on the opportunities that we think we see, the data, and the analysis that we've done so far. It's very important to level set on the information we have about our program, that we understand what conclusions can be drawn from it. We don't want to solve a problem that doesn't exist. We don't want to miss the problems and the opportunities that are there. We're going to gather your feedback in a couple of ways. One is to post the questions that we asked today, your feedback, as well as, I think really just the questions that come up today with our subsequent answers on our payments improvement website, which you paymentinitiative.org. We're also going to set up a means to answer questions offline, that is outside of the work group today. Go on with the data. Very basic, just a characterization, not, again, very different than you have seen before, I'm sure, but a characterization of the balance or the distribution of long-term service and supports by the population. Are they served in the nursing facility, which is the NF, that's the light shaded bar, and 62% of the clients in our program, this data is from state fiscal year 2011, the claims data from Medicaid. 62% are served in a nursing facility. 26% are served through elder choices, the light shaded blue. The dark shaded blue is, what are we talking about there? AAPD alternatives for adults with physical disability, that waiver. And then I'm having trouble seeing the 1% and the 3% myself. Which one would those be? Which is the 1%? Personal choice, personal care, I'm sorry, off the state plan, and living choices and assisted living waiver is the 9%. So that's by client numbers. Now to look at the spend, the proportional spend across those different categories. Nursing facilities, more expensive per person, as we know, of course, more intense service, broader level of service in a nursing home, 84% of the costs. Among long-term service and support costs, this doesn't represent all that Medicaid reimburses for these individuals. This is just the long-term services and supports. And then you can see there 16% distributed between the waivers and the state plan personal care services. That's the second bar. The third bar over there at the right is the Medicaid halo. So this is the non-long-term service and supports. These are the costs that Medicaid does reimburse for medical care, the wraparound, essentially the wraparound to Medicare which is primary payer for essentially all of these individuals. 53% for the individuals in the nursing facilities, and 47% of those wraparound costs, HALO costs, are for individuals in the community. So more of a balance on the HALO. Refer to that as the HALO and payment improvement. So at our last work group, we discussed the four main opportunities. We're going to stick with that kind of framework of the four main opportunities, and we're going to let you know where we are in the process here by which of these boxes is highlighted. The first is we're going to focus on removing the adverse incentives, that is payment incentives, financial incentives, should reward high quality and proactive resource stewardship. I would just say, level setting, Medicaid hasn't done this. Medicaid hasn't done this for any of its services, really, in any profound way. We haven't done this in medical care. We haven't done this for the other kind of health home populations and DD, or for the seriously and persistently mentally ill. We really just haven't paid for quality and outcomes, and that's a core goal. Matching level of care to needs. Clients should be provided a level of care commensurate with their level of need. This is an assessment and cost issue both. Providers should be reimbursed in accordance with that level of need for their clients, one way or another. The third opportunity is to help people get to the right setting of care. Clients need to make setting of care choices with a full understanding of long-term services and supports. And finally, coordinating care and improving care. One of the core failings, shortcomings of the services, the publicly supported services provided to individuals in this category who are dominantly enrolled in both Medicare and Medicaid, is a lack of coordination between the programs and the lack of coordination across different spheres of care, different spheres of need for the individual. Their medical, their long-term, their behavioral, and for some their developmental services are provided in silos. They're paid through silos, and we have these two programs that don't interact. So it's a shortcoming on the part of payers, in this case Medicaid and Medicare, for not getting our act together to reward outcomes for the whole individual, because we've broken that individual into their component needs and parts, and in fact we really don't even reward outcomes even for those component parts, let alone the overall outcome. So the first of the new data to share with you, I think, really, and you're going to see a similar picture for community-based services in a minute. Rising nursing home per diems have driven rapid total Medicaid cost expansion despite declines in the number of covered days. Let me also say that we could easily add to this. We do believe that rising reimbursement, especially for direct care, has led to improved quality. We didn't support quality to the extent we needed to years ago, and that needed to be addressed. And so part of what you're seeing in this picture is the amelioration of previous under reimbursement and the impact that had on quality of care. So the covered days have fallen over time from 5.2 million in state fiscal year 99 to 4.3 million in state fiscal year 12. The amount of payment, Medicaid payment per day to nursing facilities has grown, and you see some fairly rapid growth there, especially in the early part of the last decade, but continued growth about 7% per year on average over this time frame, less than that over the last few years. The net of those two is a growth of 6% per year in reimbursements to nursing homes. Let me just level set. This would be the private nursing facility, or would this include the publics as well? This is the private that we're looking at here. So we're missing in this data the state-run nursing homes.